So with that being said, all right, endoscopic mucosal resection. So it sounds like at this point, we had a couple new folks walk in, but everyone's familiar with the EMR procedure, and everyone's been in the cases and everything like that. Perfect. So what I mentioned earlier with being in the colon and kind of the lower esophagus typically, is that ring true with what you've seen here? Have you seen it in any other areas? Some. So essentially, going just into some of the reasons why those two areas specifically are more common is just because of the types of malignancies and pre-cancers that we see in the United States. So esophageal cancer is one of those hot buttons for GI. As you guys know, there's two different kinds of esophageal cancer. There's adenocarcinoma and squamous cell carcinoma. Here in the US, it's typically that adenocarcinoma that we're seeing nowadays. The reason for that is GERD, that reflux, and typically that being associated with higher obesity rates. So with obesity going up in the United States, we see that adenocarcinoma rate going up as well. On the flip side of that, the squamous cell carcinoma we see going down, and that is because it's typically associated with smoking. And in the United States, smoking numbers are consistently going down too. So at least here, typically we're looking at that adenocarcinoma, which you can see here is more common in men than women, more common in African Americans than Caucasians. And unfortunately, the survival rate, like many other cancers, is as it progresses, that 5-year survival goes drastically down. So of course, early detection is key. That's why we have surveillance protocols for things like Barrett's esophagus, which is a precursor to that adenocarcinoma. And luckily, Barrett's esophagus in those early stages of adenocarcinoma can be treated with EMR in most cases. Our other one that we're working with a lot is those colorectal cancers. So obviously, being in GI, we have screening colonoscopies, and it's literally for this high incidence rate of colorectal cancer. You can see it's now the third most common cancer in both men and women in the United States. Over 100,000 new cases of colon cancer each year, with 44,000 new cases of rectal cancer. So numbers are constantly on the rise, which is why over the years we've seen that screening age go from 50 down to 45, trying to make sure that we detect these cancers or precancers early, because as we all know, if we detect it in this early stage of a polyp, take it out, that patient doesn't have anything to worry about, and it doesn't progress to something that is a little bit more severe with, again, higher mortality rates and more complex interventions that are required. So with those polyps or those precancerous lesions, one of the things that I'm sure you guys have probably heard a lot is all these different characteristics and what physicians are classifying them as. Typically, they're able to look at these and give it a little bit more of an area of what it falls into. So we have our pedunculated polyps, our sessile polyps, our depressed lesions, diminutive and flat lesions. And all of these things start to go into that assessment that physician makes of, okay, what kind of polyp is it? What is the safest way to remove this? And make sure that we are getting this lesion out for these patients. And typically, when at least I'm explaining to people who are new to the GI world of what a physician's goal is with all of these different lesions, we are trying to treat them like they are assumed malignancy. And we know from malignancies, the goal is to get those removed from the colon or removed from anywhere in the body. So we want to make sure no matter what kind of lesion it is, we assume that it's malignant and we get that entire piece out so that patient can be sent home free of worry. So for the different characteristics, they all can fall under basically two different types of individual polyps. And at least the two most common ways I hear physicians refer to them are either adenomas or hyperplastic. Does that sound familiar with what physicians hear? So basically, adenomas, that top bucket, is probably about 70% of what polyps are out there, and it's when we talk about the pre-malignancies or the potential to turn into cancer. And those are ones that obviously are especially important to remove because if left untreated, those will progress over the next year or several years into a true cancerous lesion. The other one's hyperplastic, maybe not as high of risk of turning into cancer. However, physicians are removing all of these because there still is a chance, depending on the size of it, where it's located. If it's a little bit bigger, if it's in the left side of the colon, then they might still turn into a malignancy. So no matter what, they're trying to remove all of these lesions and treat them like they are potential to become cancer. Now, ultimately, once they see these, whether they're up in the upper endoscopy area where there's potentially like a Barrett's esophagus, or in that lower GI tract with polyps, there's different methods they can do to remove them. So again, the ultimate goal is removing them in completion, so getting the entire area out. Obviously easier when it's a small, potentially even less than a centimeter size polyp. As it gets bigger, they have a little bit more things to consider. So while here there's listed 3 different techniques for the tissue resection, the first one I would say probably isn't even listed, which we see everywhere, is just with like a jumbo biopsy forceps going and taking a bite and potentially removing a pretty small polyp. So I would say that is still pretty standard practice for those really small polyps. And again, it's because those physicians are looking at that area and they believe that that polyp is small enough or that lesion is small enough to be able to, in one bite or a couple of bites, take it off and feel confident that that has been fully removed for that patient. But as we think about trying to get an en bloc resection, getting it off in one piece, because studies again show that that is that's better for that patient to ensure that they have clean margins. We definitely see more of a movement towards, even with the small polyps, going at least towards a snare, and if not, potentially going with a snare and lift, going towards an EMR or even an ESD. So for snare polypectomies, we have 2 different types, cold snare and hot snare. So there's nothing too crazy there. For those that have been in GI longer, have you seen any sort of shift amongst physicians between hot and cold snare? Potentially more cold nowadays? And there's several reasons to that. A lot of it's to do with delayed bleeding and post-polypectomy bleeds, and wanting to use cold snare to truly be able to see what the bleed's gonna look like, and if it looks like it's gonna bleed a lot right away, they know they should treat it right away, versus when you have a hot snare polypectomy, they say it can disguise the bleed, where, all right, it's not bleeding right when we take that lesion off, but does that mean that in a few days, in a few weeks, whatever we did might kind of uncover itself and start to bleed later on? So I would say that's definitely a big shift now across the country, is going more towards those cold snares removals. The next thing I would say is probably the biggest shift is just the prevalence of EMR, and obviously why we're here talking about it today is realizing that even for those a little bit larger lesions, typically ones that are like 2 centimeters and bigger, historically those oftentimes were sent to surgery. Patients automatically, when physicians identified a larger lesion, they didn't feel comfortable with removing it. Maybe at that time the tools weren't necessarily available to them, and so they were automatically just sending them to surgery. And obviously surgery is associated with bigger bills, higher mortality or morbidity rates, and just a lot higher risk for that patient. So if we can treat these endoscopically, why wouldn't we? So that's why we have physicians doing a lot more of this. And there's different techniques that we'll dive into a little bit deeper. But in general, the overarching types of EMR is that kind of that trigger word that I've been saying a lot is that en bloc resection, getting it off in that one big piece. Or if it truly is a little bit bigger or maybe in a little bit more difficult of an area, getting it off as in few pieces as possible, but in a piecemeal resection. And that final one that we won't dive too deep in is the ESD, which I spoke about, which again is if it invades a little bit deeper into the GI tract or for a little bit larger lesions. There's now studies showing that specific types of lesions might be better off treated with ESD versus EMR.
Can I chime in?
Yeah.
We do ESD here. We've been doing that sim lab for a while now. We've done 2 cases so far with ESD involved. This one.
Yeah, no, I think that's a good addition.
That's why they're kind of like, I don't know.
Yeah,
Some of them are saying this, some of them haven't.
Yeah. So I think it's one of those things that over the next 5 years, ESD will be one of those areas that's heavily focused on in the United States, with physicians getting more comfortable with it, doing more labs like they're doing here, and seeing how important that is for patients to have an option to do that. Because again, if it's not ESD and it's too big or too deep of a lesion for an EMR treatment, then the only other option historically was surgery, which again just does not have as good of outcomes for those patients. So this provides another option for a little bit more involved lesions. So for EMR, basically the more of the characteristics of what we are treating and what physicians are looking at to determine to be an EMR. They are first looking at the size, like I mentioned. Typically once you get in that 2 centimeter or 20 millimeter area, that's when their mind is usually going to EMR. They're looking at those characteristics that I mentioned earlier with pedunculated versus flat versus diminutive. Most of them are, I would say, safe or are candidates for EMR. However, oftentimes if you see a lesion that's in that depressed category, which has like a little bit of a dip in the middle, or might be a little bit of just a purely flat lesion, not a raised flat, but just purely flat, those visual characteristics are usually indicative of what they call submucosal invasion. So it's not just that upper mucosa layer that they would be removing, it goes in deeper, which means probably not a candidate for EMR. They might have to look at other things like ESD, or potentially that means that that cancer has progressed far enough that they truly will have to do chemo, radiation. There might be lymph node involvement. So if it has progressed beyond just that mucosal layer, they're starting to step back and think, all right, something else might be better for this patient. Because it has become such a recommendation though to treat endoscopically if at all possible, in 2019 they had actually like a multi-society task force to come out with different techniques, suggestions, recommendations for physicians. So this actually lists off some of those things that those physicians are likely doing now when they're performing these procedures. Would it be safe to assume here, what does that typical procedure look like? Are they typically lifting, snaring? Are they using any APC or any like hot biopsy forceps techniques? Avulsion. So it sounds like that's pretty in line with the societies then. I think because prior to 2019, EMR was becoming very popular, but there was a lot of confusion as to what the best way to perform it was. This has really standardized what a lot of physicians are doing, at least for that lower GI tract when we're talking about using a lifting agent. And you can see that not only are they recommending lifting, the snaring, the avulsion, but it makes sure it clarifies what these physicians should be lifting with, when they should actually be performing avulsion. And you can see for the lifting portion, specifically calling out the use of a lifting agent that might be a little bit more viscous, so provides a little bit safer cushion for those patients, a little bit longer lasting. So maybe historically you guys saw physicians maybe just lifting with like a saline solution. Saline tends to dissipate pretty quickly, so when you have those larger lesions that you might have to do a piecemeal resection, so go after it in a couple of chunks, then the saline would already be dissipated. Again, it's flat, so it's not as safe for that patient. Suggesting it have a little bit of a dye in it. This is again for that safety aspect of the procedure, so that the physician can see clear delineation between the different layers of the GI tract. So blue tends to be what most physicians are using if they're mixing a solution, or a lot of the pre-made solutions have a blue tint to it, and that allows those physicians, when they start doing the removal, they can actually see that muscle layer, and if they see any striation of that muscle layer, that submucosal layer, then they know that maybe they cut a little bit deeper, which is easy to see that if you cut a little bit deeper, then you know, all right, let's just throw some clips on here to make sure that there's no sort of delayed perforation for that patient. And then in terms of the lifting agent, the final thing, which I would say is probably pretty common now that physicians aren't doing this, but using tattoo as an actual lifting agent. So this is something that while physicians aren't still using it as a lifting agent, because it can cause fibrosis of that area and it makes it extremely hard to actually lift and remove, and if those patients are going to have to come back for a second intervention, can make it extremely difficult. I would say one thing that they are still working on with physicians, typically more in like the community type setting, is actual placement of where to tattoo if they are going to tattoo. So do you guys ever see patients come in with tattoo and the physicians from wherever they were referred in from, the tattoo is literally in the polyp or has bled into the polyp? How mad are your physicians when they see that?
They're mad, and they also always biopsy it as well. And that is a big no-no. If you're going to refer out for an EMR, we don't biopsy it because
Yes.
it scars it down.
Yes, it is, I think, a constant challenge, unfortunately, still for physicians like at places like SLU that are being constantly referred in these more difficult lesions. And I think it's one of those things that I know as my job and different people that are in education roles jobs are, that we go to these other facilities that we try to educate on, because they just tattoo it and they think they need to put it right where that lesion is, when in all actuality now physicians are saying maybe you need to put it on the opposing wall so it's just pointing towards the lesion, maybe it needs to be below it, something to make it so that that tattoo, or if they biopsy it, it's not making it more difficult or sometimes impossible to remove that lesion endoscopically later on. The other thing that came out of this meeting and this task force recommendation is the part when it comes to the avulsion therapy. So everyone has agreed that the avulsion or hot snare tip coagulation after EMR provides a lot of benefits for patients. However, the main thing that needs to come across to physicians is those benefits are only seen if all of that polypoid tissue has been removed. So it's not just using that hot tip of that snare to burn off any remaining tissue. It's making sure all of that has actually been removed. And then once you have clean margins, then you're doing that avulsion or that hot snare technique. Any questions on those things? Good. So the benefits of EMR, obviously I've referenced it and they can be somewhat obvious, but truly it's for that patient that it's a safer alternative with better outcomes than having to go under a surgical intervention. So like I said, prior to EMR, a lot of these patients were just receiving, if it's in the colon, like a colectomy, or having a true partial organ removal. So we know that keeping it as endoscopic and keeping it in that realm just is a better outcome. They pay less money, safer results, it's organ sparing, and at the end of the day, if they need to come back for additional reinterventions, endoscopically is typically the answer. So for EMR, the steps that you go through in terms of like high level steps is first identification and demarcation of the lesion. There's that submucosal injection or that lifting of that lesion. And then the final step is that endoscopic snare resection. That first step is truly what makes the difference between a lift and a snare polypectomy and an endoscopic mucosal resection. So having that actual demarcation and identifying that full lesion area is the true difference maker. And when it comes to physicians and documentation, that's usually the step that is missed. And so it's always at least a constant reminder for us when we're in cases and as reps is to help make sure that those physicians are calling out that they are identifying and demarcating that lesion. We talked about this a little bit already. So when they're performing that first step, that identification and that marking of it, they spend a lot of time for these more complex areas to make sure that they are truly assessing, like I said before, with those different characteristics, the types of polyps, etc. And luckily, they have tools now to help make that even safer for those patients. I'm sure NBI, are you guys all familiar with the buttons on the scopes that change it to a little bit more of a blue screen and it helps change that look of the area? Yeah. So that's something that's progressed dramatically over the years with advancements in scope technologies and things like that, and having that as an option for those physicians makes it a little bit easier to be able to differentiate the area of concern with the surrounding mucosa, because once you get to larger, a little bit flatter lesions, sometimes it can be a little bit difficult to know where lesions start and end. And then another example of that would be chromoendoscopy. Does that word sound familiar? Do you have physicians that potentially are using like methylene blue and injecting that? I would say that has become a fairly standard practice as well, not only in EMRs, but potentially with patients that have colitis and trying to see progression of colitis and things like that. So helps again with just identifying true areas of concern. For the different procedures that, or the different techniques for those EMR procedures. Obviously, the injection is becoming fairly standard and probably the most common practice like we've talked about. But the other one is that ligation with those bands, or like a cap assisted EMR. Has everyone here seen or know what I'm referring to when I talk about that?
To do it.
So typically, upper GI, those esophageal lesions, some physicians do choose to use it in other areas, but most commonly in the esophagus, having that cap on the end of the scope to help suction that tissue up into the cap, having the bands go around it that do the ligation of it. That would be the difference in that step one. For this is how they are identifying and demarking that lesion. They're using the cap and the bands to do that. And then after the band is around it, snaring off that lesion that was marked or banded. When they do the band and when they're sucking that tissue up, basically it's sucking that top layer into that cap and providing the safety that way. So they know they just snare around that area with the submucosal providing the cushion and having the submucosa being beneath that band, if that makes sense. So a little bit different technique. It's traditionally, this has been around for a while, but traditionally they do it for things like Barrett's esophagus and more of those precancerous or early cancer lesions in that esophageal lining. Got just a couple more slides, hang in there with me. So, I've obviously talked about all the greatness of EMR and how patients truly benefit from this procedure. However, of course, there are contraindications like anything out there, and most of it has to do with typically the amount of invasion that has. So again, if our goal is to get that full cancer removed and it has invaded deeper than that mucosal area, deeper than that mucosal layer into the areas of like the submucosa or potentially beyond, or even if there might be lymph node involvement or distant metastases, EMR is probably not the answer. You're gonna remove part of a cancer, but there's other areas that are still at risk. So it's better usually for those patients to go to other measures of removal or other treatments like chemo or radiation first. After that, if it's just a size, maybe it's not invaded deeper, or maybe the physicians just choose that they think that it would be too many pieces to actually remove it, then at least they have another option with ESD now, so they're not just automatically going to surgery. There are some complications associated with it, which is why physicians do spend a lot of time to assess these and make sure they are a right candidate, and they're not just going to automatically do an EMR if there's not potential to be a curative procedure for the patient. Most of the time, those complications that we see would be the bleeding or perforations, and that's of course what we see with everything in the GI tract, any procedure that we're performing. Luckily though, that's why there's been movement towards these viscous solutions that differentiate the layers of the GI tract, and we have things like clips that we can prophylactically place after the area has been removed to make sure that not only did that patient have a successful treatment to remove that cancer, but they don't experience any sort of bleeding or perforations beyond that. And studies have shown that clips tend to do the job to help decrease these complications. And then of course, ESD, which is something that I'm sure over the months and over the years here, as the physicians start to do more and more of them, you guys will start to learn even more about, but we don't have to dive too deep into that today. So are there any questions?
I have one thing to add. If you go back like 2 slides.
Yep.
One more. Go back another.
There we go.
Another one.
Well.
That sounds like my kid. Another one. So, like she was saying, that sometimes it's contraindicated. So another thing we could do before we just refer them out to surgery is US the area if we can, and we also do this new therapeutic technique called EFTR. I don't know, and what you basically do is it's a full thickness resection. It's very high risk. You basically take a bear claw device, you bear claw it, you pull it, and you snare it all in the same motion. So you basically perforate the colon, but it's closed before you perforate it. And it takes full thickness resection. You can send it in block, the full mucosa, to the lab. It's pretty cool.
Do those patients have to spend the night at those ones? Is there a higher risk?
They don't actually.
Okay.
No. If we have something concerning about it, like, yeah. And like yesterday, we had a D3 EMR thing was like 5 centimeters, and it was huge. And with that kind of thing, we do admit them for observation of bleeding, like you were talking about.
Mhm.
So.
Which is again great just to have all those different options here, because I mean no patient wants to have surgery if they don't have to. Obviously there's some cases that it just probably is the best option, but having different avenues that you can go down, whether it be EMR, ESD, full thickness resection, definitely a great offering. And to Mitch's point, having EUS too to help just confirm the safety for that patient and to confirm that we are taking them down the correct route is key, because you would hate to go down what can be a risky route or has potential bad outcomes and then put that patient at risk and not get the job done at the end of the day.
Right, if you EFTR a whole lesion and then there's lymph node involvement, you got problems.
Yeah. Exactly. Is there any questions or anything else that has like good additions like Mitch just had? Because there's definitely there's plenty of routes and avenues you can go down with this, so it's definitely a good conversation to have and one that will continue to expand on the years. But if you guys have anything to add, I would be interested in hearing about it too. Any personal experiences from being in the cases of, wow, that was pretty cool, or oh my gosh, I can't believe we did that? Come on, one story. Alrighty, I'll let you guys get away with this one. So now that's really all I have for you guys in general. Hopefully you guys can see that this has turned into really being overall a pretty safe procedure, one that's a really good option for patients, and when done correctly, oftentimes these patients they're good. They don't necessarily have to come back. Sometimes physicians choose to bring them back after maybe a couple months or a couple of years, depending on what the procedure actually looked like. But in general, as long as that cancer truly was defined and confined to that area, those patients can be good to go.
Well, this is really good presentation, so we thank you so much.
Yeah,
It's
thank you.
well-rounded and covers everything.
Yeah.
Thank you for coming in, and we appreciate your time.
Yeah, thanks for hanging in there with me, guys. I know it's early, so.